Hello, everyone. Today I'm going to be speaking about COVID-19 vaccines, and particularly in the population of people who are living with HIV, with an extra focus on aging. Here are my conflicts of interest. So I'm going to begin by providing a very high-level overview of COVID-19 infection itself in people living with HIV. So people with HIV present really with a similar spectrum of symptoms as people without HIV. So there's no particular syndrome here, but HIV has been identified as a risk factor for progression to severe COVID-19. There's a lot of confounding variables there. It's probably not related so much exactly to HIV itself. But for example, the race and ethnicity of people living with HIV are much more likely to be Black and Latinx, which we know have a disproportionate risk on their own, as well as having an increased likelihood of significant comorbidities, potentially increased exposure in congregate settings. And there is an aspect of HIV that may make a difference, probably does, and that's the immune status of the patient. So advanced stage of disease or a low CD4 count likely drives a lot of this risk. And then relevant to today's talk, age has been identified specifically among people with HIV as a risk factor for progression, particularly age 70 years or older. In regard to treatment, it's really no difference for people living with HIV compared to the general population. You still will use dexamethasone, remdesivir, immune modulator therapy as available. The only extra wrinkle is just to make really go through the drug interactions that might be there. And in terms of ART should be continued throughout the course of COVID-19, and there's no particular regimen that is better or worse for COVID. So really no adjustment to regimens are indicated. But we would rather not people get sick. We'd rather prevent COVID-19. Prevention recommendations are generally the same as in the general population. And the key modalities for prevention, at least biomedical prevention, is monoclonal antibody therapy, particularly for post-exposure prophylaxis. So in the US, there is an EUA for the Regeneron antibodies to do this. And then, but the mainstay of this is COVID-19 vaccination. And we really have the best data for Moderna, Pfizer, AstraZeneca, and the J&J vaccines. I mentioned masking guidelines here because we don't want to forget those. They are really important, especially for more immunocompromised patients with HIV. But, this is very dynamic. Depends on your pandemic locally and as well as kind of your local culture, let's say. Now, people with HIV were not formally excluded from these trials, and that was because of some really great advocacy among people with HIV. Though, it's not like a tremendous amount were enrolled, but there were about 2,000 people with HIV who were included in the formal phase 3 efficacy studies. Really most of them were enrolled in the J&J trial because they had a very large arm of it that took place in South Africa. And you can see the numbers in the table below and that J&J had about 10 times as many as the rest of the studies. Now, even though people with HIV were enrolled, not all of them were. So anyone who was severely immunocompromised was excluded from these studies. And that was generally defined as the CD4 count less than 200. Now, even with these small numbers, in combination, you can kind of look at this, and there was no safety signal or unusual concerns that came up with this particular population. Now, the sample sizes are definitely too small to look for efficacy, but it's generally assumed to be the same as the general population. And that's because, as I'm going to show you, the immune responses were also about the same between HIV and non-HIV. So this is a study that looked at the AstraZeneca vaccine. Here, there were 104 people with HIV and 70 that did not. And this is in South Africa. And they all received AstraZeneca, the full 2 doses. And in this study, and this is pretty true across all the studies, the people with HIV in this study were pretty well controlled. So they were on ART, they had great CD4 counts, they were virally suppressed, and they were also younger. So the median age here is 40-year-olds, for example. And often these studies are not actually reporting the data stratified by age. And so it can be difficult, if not impossible, to disentangle those effects. But in this study, there was no difference in the vaccine reactions or adverse events that were observed, and no difference in immune responses between these two cohorts. On the right is a figure that's showing the antibody levels at day 0, day 28, and day 42, and breaking it out by HIV negative and people living with HIV. And you can see here, there's no difference in those concentration levels. And this was confirmed in an additional study in the UK. This is a more formal study, prospective study, single arm open label within a larger protocol. And in this study, adults aged 18 to 55 years old with HIV were enrolled, and they were also very well controlled on ART. They got 2 doses of the AstraZeneca vaccine, and all of the outcomes here were compared with an HIV uninfected group from the main study, which is important because that's a prospective and concurrent control group. And the immune responses were similar across the groups. And this is actually the only study that I could find that actually comments on age. Now, remember, the age range in the study is pretty narrow, 18 to 55, but they found that there was no difference in immune responses by age. These are the figures showing antibody levels on the left and T cell responses on the right in the 2 different cohorts, HIV positive and HIV negative over time, showing that there's no difference in the immune responses. And this is the scatter plot that is looking specifically in the HIV infected population, looking at anti-spike ELISA titers by age. And here there was no association, but you can see that it cuts off at 55. So really in the general population, it's the effects on antibody levels are seen, above 65 years old. So this would not be detected in a study like this. Now, what I was showing you before was AstraZeneca, but this data has held up for Pfizer. This is a prospective open label study in South Africa. Oh, no, actually in Israel, 143 people living with HIV and healthcare workers as a control. So kind of a different population, but okay. They all got Pfizer. It was an older group, about 50 years old in this group, with some range up into the 60s. And what they found here is that, again, antibody levels were generally similar. Now, they included a few more people in this that had lower CD4 counts. And in some of the studies, like the IgG level looks slightly lower. But if you look on the right, this is the neutralization titer, which is the very likely the correlate of protection. And there's no difference between the 2 groups. They did comment on age here, though they kind of lumped the 2 cohorts together. And as they went up in age, and remember, this cohort did include some older folks, age was significantly associated with lower antibody levels. They didn't stratify that by HIV status, but considering that they had more than 100 people with HIV in this cohort, I think we can assume that age, like everyone else, really affects antibody levels, especially in the upper level. And for Moderna, similar data. This is a tiny study of 12 people with HIV and 17 healthy donors, ages 25 to 59, who received the Moderna vaccine. And there was no difference in antibody levels, shown on the right, no difference in cellular immune responses, but here the results were not reported by age. If you dig into the supplemental data, you can see there is a little bit of data with the ages and a little bit with the CD4 counts. A couple of these folks had low CD4 counts, but not a lot of detail. So a couple words about boosters, or as we sometimes say, supplemental shots. So people living with HIV are eligible for supplemental immunization. And this is not called a booster because, in fact, the idea is that they might not have had a robust immune response in the beginning. But this is really for moderate to severely immunocompromised people with HIV. And among the different organizations that provide guidance for us, this would really be defined as advanced HIV disease, and it's provider dependent. So there's subjectivity there, but generally speaking, CD4 count less than 200. But there's actually no clear data out there characterizing vaccine immunogenicity in advanced HIV. So that is a nice little research project for somebody. And the reality is that age alone is probably going to qualify a person living with HIV for a booster shot. pending FDA guidance. So I'll finish up with 2 slides on the summary here. So people with HIV are at increased risk of severe COVID-19, particularly if they have a low CD4 count. COVID-19 vaccination is the mainstay of SARS-CoV-2 prevention. About 2,000 people with HIV were included in the phase 3 efficacy studies, and no safety signals have been observed. And multiple studies demonstrate that people living with HIV generate equivalent immune responses to those without HIV, with the caveat that these are pretty well-controlled patients. And people with HIV are eligible for supplemental vaccine doses, at least in the United States, if they have advanced HIV disease, which is really defined by the provider. In regard to age specifically, age is an independent predictor of severe disease in people living with HIV. The vaccine studies are pretty limited by the narrow age range of their participants, and only a handful of them were actually over 60 years old. And whatever data we do have does not suggest a marked effect by age on antibody levels, but we don't have that older cohort to really look at. Age will likely be an additional indication for boosting, and that's going to apply to people living with HIV. But really, finally, age-specific data in people with HIV is very thin and definitely needs further study. Thank you very much.